Hello everyone. In this video, I am going to discuss one of the most favorite topic for examiners, that is malaria. Malaria is always a hot topic of discussion during practical as well as theory examination. But students unfortunately ignore this topic. Every year, either in mains or supplementary exam, you will get one question, either in the form of essay or short note from malaria, complications of malaria, that is the so-called cerebral malaria, and the treatment of complicated and uncomplicated malaria, malaria in pregnancy, along with that, chemoprophylaxis of malaria. Without much introduction, let me take you directly towards the topic. William Osler once said that humanity has three great enemies. One is fever, one is famine, and one is war. Out of that, the most terrible is fever. Why? Because he target the one disease, that is malaria, which is a disease for the tropical countries in this world. As you all know, malaria is a protozoan disease that is transmitted by the bite of infected female Anopheles mosquito, and it is one of the most important of the parasitic disease in humans. Coming into the epidemiology of malaria, it occurs throughout the most of the tropical regions of the world, including India. As you can see here, the color, is light orange. That means Plasmodium falciparum and Plasmodium vivax. Out of that falciparum, it is the most common species of malaria that is found in India. Then, let us see what are the different classes of Plasmodium species which infects humans. Falciparum, vivax, ovale, naulacea, and malaria. In that, the approximate duration of the erythrocytic cycle is around 48 hours in falciparum and malaria, around 50 hours, but still we say 48 hours in Plasmodium ovale, and 72 hours in malaria, and nearly 24 hours in naulacea. Each of these species has special attraction towards different age groups of RBCs. For example, younger cells by naulacea and falciparum, reticulocytes and 2 weeks old RBCs by vivax, only reticulocytes by Plasmodium ovale, and remember Plasmodium malaria mainly affect older cells. Banana-shaped gametocytes are one of the characteristic morphology of Plasmodium falciparum. Schaffner's dots with irregularly shaped large rings and trophozoites of vivax. Tufted ends with Schaffner's dots again of ovale. Band or rectangular forms of malaria. And remember, Plasmodium naulacea resembles that of Plasmodium falciparum in early stages, and in late stages it resembles that of Plasmodium naulacea. Relapses are caused by vivax and ovale. Recrudescence are caused by falciparum and malaria. So these are the general introduction you must know about the various species of Plasmodium. So how does the Plasmodium causes infection? Female Anopheles mosquito inoculate the so-called plasmodial sporozoites from its salivary gland during a blood meal. Okay, and this is the picture. Okay, it is the sporozoites. Once that is done, very quickly from the bloodstream, it reaches the liver where they invade the hepatic parenchymal cells, and a period of asexual reproduction takes place. During this asexual reproduction, there is a amplification process which takes place, that is called intrahepatic or pre-erythrocytic schizogony. Why it is called pre-erythrocytic? Because this is the stage that happens outside the RBC. And here, a single sporozoids produce 10,000 to 30,000 of merozoites. And the infected liver cells finally burst, discharging the motile merozoites into the bloodstream, and it is this merozoites which invades the RBCs to become trophozoites. Okay, yes. So that multiplication time is actually the so-called as 48 hours, 50 hours, 72 hours, and 24 hours. That is what we discussed in the introduction part. Remember, the merozoites is attached to erythrocytes with the help of certain receptors, especially the receptor for Plasmodium falciparum is called as erythrocyte binding antigen 175 or glycophorin A. There is another product, that is merozoite reticulocyte binding protein homolog 5, that also what plays a critical role in binding to red cell basic. So as I told you, sporozoites, liver, merozoites, RBCs, and it is within the RBCs. Okay, what will happen? It undergo lots of reproduction cycles. Okay, multiple nuclear divisions has takes place. Okay, this is called as the so-called as intraerythrocytic life cycle. This is so-called as the intraerythrocytic life cycle. Okay, multiple nuclear division takes place here. And as a result of multiple nuclear divisions, what will happen within the RBCs? Two structures will be formed. Okay, two new life cycle stages will be formed. They are called as the male and female gametocytes. And in the blood, we will be having this male and female gametocytes, which will be finally taken by whom? The female Anopheles mosquito during the blood meal, and the male and female gametocytes fuse, okay, as a result of sexual division or meiosis to form a zygote, which occurs in the insect's midgut. Okay, so the zygote is formed within the mosquito's gut, and this cycle repeats. So very, very important. This is an ingest detail about the malarial life cycle. Okay, once coming into that, let us discuss about the pathophysiology in bit detail. Number one, the erythrocytic changes. I told you that using certain receptors, the one such receptors for Plasmodium falciparum only, I told you Plasmodium falciparum, what? Erythrocyte membrane adhesive protein that helps the attachment to receptors on venule and capillary endothelium, and this phenomenon is called as cytoadherence. There are various other receptors that causes agglutination or clumping of the RBCs. And this clumping up of the RBCs will cause what? Sequestration of in the vital organs, especially the brain, and it will occlude the tiny blood vessels in the brain, and this plays a very, very critical role in the pathogenesis of the severe complicated falciparum malaria, the cerebral malaria. Okay, yes. Then remember, in other malarias, why? Because this Plasmodium falciparum cytoadherence protein is responsible for this. That is why Plasmodium falciparum causes cerebral severe complicated malaria. Whereas in other human malarias, okay, this significant sequestration does not happen. And as I told you, Plasmodium knowlesi, okay, there will be high parasite densities within 24 hours of time itself. That is why I told you the erythrocytic time frame for the Plasmodium knowlesi is just 24 hours asexual life cycle. Coming to the host response. So initially, what will our body will do? Okay, it will activate some non-specific defense mechanisms. The spleen removes the damaged ringworm parasites through a process called as pitching. Okay, and during this time, what will happen? The so-called as I told you in the clinical cycle that the liver, okay, will produce the merozoids, and the moment the merozoids are released into the bloodstream and it start invading the RBCs, the clinical manifestation rupture. And what is the first clinical manifestation the body will show? That is fever. Very, very important. That is fever. And the temperatures of more than 40 degrees Celsius actually damages the mature parasites in untreated infections. Okay, that is responsible for the spikes. That is actually responsible for the regular fever patterns. Okay, but that is actually, okay, I am getting the infection. Within a period of time, what happened? The sporozoids enters the liver, and from the liver, merozoids will be formed. And the time the merozoids are released into the bloodstream, I will get a fever spike. And this fever the temperature of my body keeps on increasing, and it reaches a point called as 40 degrees Celsius. At 40 degrees Celsius, what will happen? The mature parasites in the blood, dies. Again, sporozoids enters the liver. Hepatic parenchymal cells produce merozoids, another spike. So this is actually happens. So this is called as the different fever patterns, the quotidian, so called as the daily, tertian every 2 days, cotton every 3 days. All these, which happens in patients who don't get proper treatment. If they are getting proper treatment, these fever patterns won't happen. Okay, then we all know that the geographical distribution of thalassemia, sickle cell anemia, okay, G6PD deficiency, hereditary ovelocytosis, all those decreases the risk of Plasmodium falciparum infection. Okay, yes, I hope you know the reason for that. Why? Because the sickling RBCs have low oxygen tension, and Plasmodium falciparum cannot survive in this low oxygen tension. That is the reason why these people are protective from malaria infection. Okay. Once that is done, let us see about the clinical features. The first symptoms will be non-specific. Headache, fatigue, abdominal discomfort, muscle aches followed by fever, like of a minor viral illness. Okay, sometimes nausea, vomiting and orthostatic hypotension are also common. But the so-called as a classic malarial paroxysms, which includes the fever spikes, chills and rigor, which occurs at regular interval, it is actually very, very rare to find that clinical presentation in practical life. Coming into the most deadly manifestation of Plasmodium falciparum malaria, that is called severe falciparum malaria. If we treat a patient promptly, immediately, clinically, the chance of survival is very, very high. But at the same time, it does not occur. Severe falciparum malaria occurs. In that, cerebral malaria, where coma is a characteristic and ominous feature of Plasmodium falciparum malaria. When I was an intern, I saw a case of cerebral malaria, okay, where the patient was brought, okay, it was a 10-year-old, 12-year-old boy who was brought unconscious in a state of coma. And after aggressive treatment over nearly 14 days, we revived him back. So cerebral malaria actually manifests as a diffuse symmetric encephalopathy. Focal neurological signs are usually unusual. It is very uncommon. The corneal reflexes will be usually preserved except in case of coma. Plantar reflexes may be flexor or extensors. Okay, papilledema and cotton wool spots will be seen on fundoscopy. Then seizure activity is particularly common among children. And remember, when it comes to children, there are certain prognostic factors that actually decide how within how much time the patient will be recovering. Okay, and remember, in children who survive cerebral malaria, there will be persistent language deficit. There will be deficit in learning, planning, and executive functions, as well as memory and non-verbal functioning. Very, very important. There is increased chance of epilepsy. Okay, post recovery. So what are the manifestations of severe falciparum malaria? This is very, very important. It can be classified into major and minor. In major, unarousable coma, whereas the GCS will be usually less than 11. Then acidemia or acidosis, whereas the arterial pH is less than 7.25. Very, very important. Asked in Ames also, previous year question. Okay, the lactate level will be more than or equal to 5 millimole per liter. Again important. Severe normochromic normocytic anemia with a hematocrit less than 15%. Plasma creatinine more than 3 mg per deciliter, or blood urea more than 20. Non-cardiogenic pulmonary edema, very, very important. Hypoglycemia with plasma glucose less than 40 mg per deciliter. Systolic blood pressure, less than 80 in adults or less than 70 in children. Bleeding or disablated intravascular coagulation and convulsion, that too more than 2 episodes of generalized tonic-clonic seizures in 24 hours. The other features are hemoglobinuria, extreme weakness, hyperparasitemia, and jaundice. Jaundice and all very rarely seen, okay, unless and until the liver is affected. So these are the various manifestations of severe falciparum malaria. Remember, GCS less than 11, 7.25 arterial pH, hematocrit less than 15%, creatinine more than 3, blood urea more than 20, non-cardiogenic pulmonary edema, plasma glucose less than 40, systolic BP less than 80 with capillary refill time more than 2 seconds, disseminated intravascular coagulation, and more than 2 episodes of GTCS in 24 hours. And what are the features? It indicate poor prognosis in severe falciparum malaria. Number 1, marked agitation. Number 2, hyperventilation. Why? Because it causes respiratory distress, which further aggravates non-cardiogenic pulmonary edema. Low core temperature less than 36.5 degrees Celsius, bleeding, deep coma, repeated convulsion, anuria, and shock are again poor prognostic features. What are the poor laboratory features? Hypoglycemia less than 2.2, okay, that is less than 40 mg per deciliter. Hyperlactinemia, then arterial pH less than 7.2, serum creatinine, if it is more than 265, that is more than 3 mg per deciliter. Then elevated total bilirubin more than 5, leukocytosis more than 12,000 with PCV less than 10%. Remember, criteria is less than 15%. If it is less than 10%, poor prognosis. Low platelet count, DIC features, hyperparasitemia, all those are associated with poor prognostic features in case of cerebral malaria. Remember, hypoglycemia, it is actually one of the most important and common complication of severe malaria associated with very poor prognosis, especially in case of children and pregnant women. Okay, what is the reason? Because of the failure of hepatic gluconeogenesis, because of the extreme parasitemia. Then acidosis, it is responsible because of the accumulation of the organic acid, especially lactic acidosis. Then non-cardiogenic pulmonary edema, which occurs because of the underlying respiratory distress and everything. And remember, the another most important cause of non-cardiogenic pulmonary edema, we will treat the patient, okay, with the aggressive IV fluid, so that also causes this. Then renal impairment, very, very important. Acute kidney injury is very common in case of severe falciparum malaria. This is mainly because of the erythrocyte sequestration of the renal microcirculation. Okay, yes, and this is the eye. This is again a PYQ in Ames. What is the eye features in malaria? It is the perimacular whitening and pale centered retinal hemorrhages. Papilledema and cotton wool spots are other non-specific findings. Coming into the hematological abnormalities, I say hematological abnormalities may be either because of this hemolysis, okay, hemoglobinuria, jaundice, as I have told you, and the another one thing is very, very important. It is mainly because of the disseminated intravascular coagulation. Thrombocytopenia is officially associated with Plasmodium falciparum only in severe conditions. In mild cases, thrombocytopenia is not well appreciated. And liver dysfunction, as I told you, because of the hepatocyte damage, there will be liver dysfunction. And remember, this malaria will be very, very severe in HIV, AIDS, and other immunocompromised patients. Chest infections, catheter-associated urinary tract infections are also very common in prolonged bed stay patients. Remember, coming into malaria in pregnancy, which causes early fetal loss, especially in the first trimester. Remember, it is also associated with increased mortality rate. Okay, and remember, what are the complications which can occur very commonly in pregnancy? It is anemia, number one, number two, hypoglycemia, number three, acute pulmonary edema. Why? Because in pregnancy itself is a high cardiac output state. Okay, yeah, there is increased plasma volume. That is the reason what acute pulmonary edema is very common, especially in malaria in pregnancy. And when coming to malaria in children, metabolic acidosis, anemia, congestive cardiac failure is also very common. But remember, convulsions, hypoglycemia, convulsions, very important. I told you, convulsions after recovery from cerebral malaria, also the incidence of convulsions or epilepsy is very high in children. Number two, there will be memory deficit, there will be executive function deficit, learning deficit, there may be also permanent impairment of the developmental delay, permanent impairment of the developmental milestones even in children. Coming into transfusion malaria, the incubation period is very short in case of transfusion malaria. Why? Because there is no pre-erythrocytic stage in blood transfusion. Okay, so what is that? Sporozoids is not seen. It is only merozoids. Okay, it is the merozoids which is straight away. Okay, the so-called as the sporozoids is not seen. It is only the so-called as, sorry, it is not merozoids. It is the trophozoids. So trophozoids are the infectious stage in case of blood transfusion. Why? Because there is no sporozoids, and since there is no sporozoid, there is no merozoids also. And remember, as I told you, in relapses, okay, relapses occurs in case of vivax and ovale. There is an intermediate stage called as the hypnozoids. Hypnozoids are what? They are actually the dormant stages of plasmodium which occurs in the liver. Okay, that is actually the hypnozoids. And it is a trophozoids, that is the infectious stage in case of transmission malaria. No sporozoids and the merozoids. Okay. And in this pathophysiology stage itself, I think I forgot to mention about the trophozoids. Trophozoids are found as a part of intra-erythrocytic life cycle. Okay, it's a intra-erythrocytic life cycle. Okay, once that is done, let us see about the chronic complications of malaria. Again, a very important short note question, that is hyperactive malarial splenomegaly. Remember, this occurs in malaria endemic regions in tropical country. This is actually an abnormal immunological response to repeated infection, which is characterized by massive splenomegaly, hepatomegaly, marked elevation in serum IgM and malarial antibody titer, also associated with lymphocytosis. Okay, remember, it is IgM antibody to CD8 plus T lymphocyte. It is almost like infectious mononucleosis which occurs in case of Epstein-Barr virus infection. So there is uninhibited B cell production of IgM and formation of so-called as cryoglobins. Cryoglobins are nothing else but what? IgM aggregates and immune complexes. And remember, this causes lymphoid hyperplasia and finally produces splenomegaly. This is called as hyperactive malarial splenomegaly, where the patient characteristically present with a mass or a dragging sensation in the abdomen, okay, or there will be abdominal pain, sharp abdominal pain, which is suggests perisplenitis, that is infection of the splenic capsule. And remember, it is also associated with the pancytopenia, anemia, thrombocytopenia, and leukopenia because of the hypersplenism. And remember, in hyperactive malarial splenomegaly, in blood smear, you can't see the malarial parasite. Okay, usually what we do, we will ask them to receive anti-malarial chemoprophylaxis. I will tell what are the chemoprophylactic agents which can be given in malaria. If we don't treat it properly, it may cause lymphoproliferative symptoms. Okay, also like Burkitt's lymphoma or EBV associated lymphoma, like that. Coming into cotton malarial nephropathy, just remember, it is plasmodium malaria which can cause immune complex deposition formation, especially subendothelial deposits formation, okay, which can be appreciated on the electron microscopy, and it infiltrates the glomeruli PCT, and that is responsible for causing the nephrotic syndrome like picture. Okay, that is very important. Again, it is like an immunoglobulin deposition in the walls of the glomerulus. Okay, remember, it is Plasmodium falciparum. Coming into the blood films of trophozoids. Okay, in that just remember one thing. Okay, I will see this is the banana shaped gametocyte of Plasmodium falciparum. Okay, yes, this is very important. This is called the ring or a cold form. Fine. And this is that of the Plasmodium vivax. Okay, yes, and here you have to just remember this picture. Okay, this picture alone. Yeah, this is the so-called as the ring or a, so you can see two ring form. This is the ring or acole form, which is mainly seen in case of Plasmodium falciparum, and if it is single, it is usually associated with it is Plasmodium vivax. Okay, then another important thing, yes, we have something called as RDT, rapid diagnostic test, which detect Plasmodium falciparum specific histidine-rich protein 2 and lactate dehydrogenase. This is actually the test of choice in case of malaria endemic regions and malaria resistant regions in, that is, northeast states of our country. Yes, we have two types of smears. One is called as thick smears and thin smears. I hope you remember all those things from your microbiology. Okay, yes, and coming into the laboratory findings, usually there will be normochromic normocytic anemia, there will be leukocyte count will be usually slightly normal associated with monocytosis and all sometimes. Okay, the ESR may be elevated, C-reactive protein will be also elevated, then blood urea, nitrogen, creatinine, everything will be normal in uncomplicated malaria, whereas the pH and everything goes down in case of complicated malaria. And remember, children, the one thing, yes. Yes, I told you this Naulesi. I told you the early stages and late stages. Okay, initially in the first table itself, I have told you that in Naulesi, the early stages resemble that of Plasmodium falciparum, and late stages resembles that of Plasmodium malaria. Okay, that is about Plasmodium Naulesi. Very very important. Okay, once that is done, just remember two things. What? Thin smear along with thick smear. Yeah, so what are the standard methods? It is the thick blood film, okay, and then thin blood film, then the card test, then LDH card test, okay, and another one thing is microtube concentration method with the acridine or orange staining, okay, which will help to identify the so-called as Buffy cot. Okay, out of that, the sensitive is thick blood film. Species specific thick film is actually used to for the quantification, okay, yeah, for the assessment of parasitemia, whereas thin blood film helps to identify what species it is. Okay, then card test and everything I told you in case of northeastern states we are doing. Yes, coming into the most important part, that is uncomplicated malaria treatment. If it is chloroquine sensitive strains, we will straight away go for chloroquine, remember. Okay, no need to remember the dose. Then coming into for Vivax and Oval, to prevent relapse, we have to give additionally, in addition to chloroquine, we also give Primaquine. In G6PD deficiency, Primaquine should not be given. So in that case, we use single dose Tafenoquine. What is the dose of Primaquine? Actually, it should be given for 14 days. Whereas in case of Tafenoquine, it is a newer drug that can be given in case of G6PD deficiency, which is usually a single dose. Plasmodium falciparum malaria, remember, it is always artesunate. Okay, artesunate plus sulfadoxine pyrimethamine. Okay, that is in case of normal states, and in case of northeastern states, it is always artemether lumefantrine. It is AL here, and it is always here ASP. Artesunate with sulfadoxine pyrimethamine and artemether lumefantrine. Okay, and in case of severe falciparum malaria, remember, it is always IV artesunate. It is always IV artesunate. If unavailable, we go for IM artemether. If unavailable, we go for quinine. Okay, quinine plus clindamycin is usually the treatment of choice in case of complicated malaria in first trimester of pregnancy. Why? Because ACT is contraindicated in first trimester of pregnancy. Primaquine is contraindicated in all trimesters of pregnancy. Okay, and remember, artesunate is IV injection, but our our artemether is IM. Okay, and then coming into the various properties of antimalarial drugs, remember quinine, it has good oral and IM absorption. Okay, but the problem, the most common side effect is hypoglycemia, hypotension, synconism, tinnitus, hearing loss, vertigo, prolonged QT interval, everything. And chloroquine, again, good oral absorption, causes nausea or dysphoria and pruritus, and QT prolongation is also associated with chloroquine. Then remember, Primaquine, it is used for the radical cure of Plasmodium vivax and Oval because it kills the hepatic forms, and it is associated with nausea, vomiting. I told you Primaquine precipitate prehemolysis. That is why it is contraindicated in G6PD deficiency. It also causes methemoglobinemia. Then mefloquine, it is usually for prophylaxis actually. Remember, again it's a PYQ. Which of the following drugs causes neuropsychiatric manifestations, convulsions and encephalopathy? It is mefloquine. Okay, yes. Then acute hypotensive shock. Okay. Then bullseye retinopathy, again it is associated with chloroquine. Then artemisinin derivatives, anaphylaxis, it causes. Then tetracycline, doxycycline for prophylaxis, it causes renal failure. But remember, tetracycline is safe in renal failure. Okay, yes. Okay. So tetracycline and doxycyclines, and tetracycline causes renal failure in patients, okay, with impaired renal function. So in that cases, we have to go for doxycycline. Doxycycline is safe in renal failure. Okay, there is a correction. Doxycycline is safe in renal failure. It also causes what? Yeah, GI tolerance, deposition in growing bones and teeth. It also causes benign intracranial hypertension. That is why doxy, all those compounds, there is a risk of teratogenicity. That is why they are contraindicated in pregnancy. pregnancy. Okay, just when it comes to artemisinin derivatives, just remember about anaphylaxis, urticaria, and fever. They have good oral absorption. I told you artemether is IM, artesunate is IV. Okay, and yes, in case of acute renal failure, adequate rehydration, but remember we should prevent volume overload, otherwise what will happen? Yeah, acute pulmonary edema and respiratory distress syndrome will happen. You know how to manage acute pulmonary edema and all, it is a separate video. Positive pressure ventilation, what prone position, low PEEP, all those ventilator settings. Then coming into hypoglycemia, 20% is dextrose, 2 ml per kg over 10 minutes should be followed by an infusion. Then sepsis, very uncommon. Then other complications, I told you, convulsions and everything. And coming into the chemo prophylaxis, the first drug we use is mefloquine. Okay, currently we are using two drugs. One is mefloquine and another one is doxycycline. Okay, mefloquine and doxycycline are the current two drugs. This is actually from Harrison. Okay, Harrison is as per the US guideline, but just remember in India we are either using mefloquine or doxycycline. Okay, yes. And yes, see, doxycycline prophylaxis in areas with chloroquine or mefloquine resistant, okay, begin 1 to 2 days before travel. Okay, and but doxycycline is contraindicated in children aged less than 80 years and pregnant women, and has to be used for how many? 4 weeks after leaving such area. And next one is so this is 1 to 2 days before travel, continue to 4 weeks after travel. Here it is 1 to 2 weeks. Mefloquine, it is 1 to 2 weeks before travel to 4 weeks after travel. So it is 1 to 2 days here, it is 1 to 2 weeks here. I told you mefloquine is associated with neuropsychiatric manifestations, very important. Okay, and it is also has known to cause what cardiac conduction abnormality. That is why mefloquine should not be given in cardiovascular disease patients. Okay, then another thing, yes, what, yeah, the dose is doxycycline has to be given daily. Okay, the doxycycline has to be given daily, whereas my mefloquine has to be given once weekly. This is another important difference. Mefloquine is once weekly, doxycycline is once daily. Yes. So with this, just I have completed the so-called as the malaria. Remember the prophylaxis of malaria, doxy, meflo, then what are the complications, then you must know all the side effects of these drugs, then uncomplicated and severe falciparum malaria treatment, methods of diagnosis, the so-called as the newer rapid diagnostic test, then the morphological slides. Remember, hyperactive malaria splenomegaly, which is a short note, transfusion malaria, malaria in pregnancy, children. Okay, then what are the poor prognosis factors in case of severe falciparum malaria and the clinical manifestations of severe malaria. Then cerebral malaria. Cerebral malaria has been an essay once in your university exam, and the pathophysiology, epidemiology, the life cycle images, and the various species of malaria.